So now I have the job. So you guys gave this embarrassment of riches, right? So there's much deeper understanding of the biology than we've heard about the new toys to play with. And now I have to kind of clean up and say, all right, what are we going to do about all of this in clinic to try to put this, to try to put all the data together. So, okay, we already heard that we beat 7 and 3, right? So that's going to be a theme, by the way, for those of you who are heading into the ASH meeting. Beating 7 and 3 is going to be a central theme of the ASH meeting, including in a plenary session. But for FLT3 mutated AML, we know that the standard chemotherapy of 7 and 3 has been beaten both in RATIFY and in Quantum First. When you put the studies side by side, you want to think just about a couple of things. So Quantum First, quizartinib is ITD only. We heard that. We also see that that went up to age 75. RATIFY only went to age 60. Patients over 60 are not served well with getting 7 and 3, no matter what, though. So it offers a question immediately about, are the older patients truly fine with 7 and 3 and quizartinib, or can we do better than that? And we're going to see some of those data. We know that the CR rates are not actually what drives this. The CR rates don't look that different, but the survival actually does. And so we know that the application of a FLT3 inhibitor to a standard backbone is standard of care. What we're worrying about is the older patients who don't seem to be served well yet. Now, if you look at the long-term follow-up, so again, I'm already setting the stage. We have older patients who are the primary, population for AML, median age 67 to 70. But you also have that a lot of the cures that we have been seeing, and if you look at the 10-year survival data for RATIFY, you can see this, are still driven by allotransplant. So there's an awful lot of patients in the past who have landed on these 10-year survival curves because of their allotransplant. Wouldn't it be nice to get rid of that too? So not to put the transplanters out of business, but what we are looking for is ways to have all of the patients with FLT3 mutations, not only the younger ones who are served best. We do know from Dr. Sierra's presentation that that FLT3 mutations are less common among the older patients, but there are more older patients. So this still represents a very strong unmet need. FLT3 inhibitors are resulting in benefit. Transplant is still driving the survival in these data. So what you can see, though, is that the treatment algorithms for AML are getting actually complicated. And this is nice because it used to be a very short lecture to give for AML that you give 7 and 3 or you're in desperate trouble. Now we've got all kinds of things here. We've got all kinds of buckets that are driven by the different biology. But this is one of the first, actually, that I've seen published that splits specifically this age 60 to 75. And this is just an interesting thing to think about clinically, that there is a zone of patients between 60 and 75 that some of these patients are perfectly able to get standard intensive therapy, but are they well served by it? Now, here you can see very clearly in this particular algorithm, and again, this is just a suggested algorithm, that for the FLT3 patients, even 60 to 75, it's intensive chemotherapy plus quizartinib for the ITD patients or midostaurin. But what you're starting to see here, and I'm not going to take the time to go through every arrow here because we'll be here all day. But if you look carefully, you are seeing different buckets. So you're seeing the biological buckets, and then you are also seeing all kinds of arrows based on MRD. MRD is now everywhere, driving treatment decisions, and the specificity of MRD for the molecularly defined subgroups, core binding factor, FLT3, NPM1. MRD is standard of care, and not only that, but MRD as measured by what? And I'm going to talk about that in a moment. So here you see in Quantum First that you're looking at what is transplant actually doing for these patients? So if you look on the left, the overall survival of patients who got an allo transplant. Okay, if you got an allo transplant, it's better than if you didn't. But what I think Jorge Cortez was starting to point out is that, well, what about patients who can't get an allo? What about patients who might be able to go on to maintenance therapy with a FLT3 inhibitor without getting an allo? If you get the total package and you get a FLT3 inhibitor up front and you're MRD negative and you get an allo and then you get maintenance, do you really need all of that therapy? This is what we are trying to figure out. And here you can see that allotransplant and quizartinib were significant predictors of prolonged overall survival. If you're not going on to an allo, you probably need maintenance. But where does MRD fit into all of this? And can some of the patients actually be spared endless therapy with a FLT3 inhibitor either before or after an allotransplant? Nobody wants to be on treatment forever. So here's where MRD comes in. Now, this is very important to keep in mind that not all MRD is the same. That is the topic of another webinar, which we probably need. But MRD, when you are talking about FLT3 patients, needs to be this high sensitivity PCR NGS. This was actually specifically developed for the Quantum First trial. You can see here that this is a complex version of MRD. This is, again, not flow cytometry, and this is not the same test as what you're sending to make a diagnosis of a FLT3 mutation. This is different. And I think it's very, very important for everyone to work out with their pathology department. What is it that they have on site? Which assay is it? Might they need to be sent out in the United States? And actually in much of the EU, there is a companion diagnostic, which is this ultra deep NGS PCR. But make sure you're taking the right test, because this is what's going to drive everything. So what you're going to start seeing is MRD, 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 along with FLT3. Now, importantly, we are talking about MRD for FLT3-ITD, not for TKD. So that's mistake number one that gets sent, that if you're sending the wrong assay for the wrong type of mutation, that's not going to help. For ITD patients, the so-called Morpho trial was largely advertised as a negative trial because it didn't meet the primary endpoint. But what it did show was a very strong benefit for gilteritinib in patients who had a FLT3 mutation either before or after transplant. If you're MRD positive, there was a benefit for this agent. Conversely, if you are MRD negative, you may not need a FLT3 inhibitor, so you can spare the patient's therapy. And what is a theme over and over again, and you'll hear this a million times at ASH, is that by the MRD, by a FLT3 high sensitivity assay, there is no amount of leftover FLT3 that is okay. A little bit is not okay. A tiny bit is not okay. It needs to be zero, undetectable. So here you can see for maintenance, the impact of MRD. In the placebo arm, patients were MRD positive were relapsing quickly. ITD clones, what I'm talking about is that this was irrespective of the treatment arm. The repeat statement, again, the take-home message is you can go deep, 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 but any level of MRD was not okay and was resulting in relapse. And in this setting is where the inhibitors were actually of benefit. And again, for the gilteritinib trial, it was in the peri-transplant setting, so before and or after. Now, in older patients, again, so here what we're talking about should be leading you to the question of, well, what if you get to MRD negativity? Might you not need a transplant? Is it possible that we could be talking about not transplanting FLT3 mutated patients? Well, in older patients, you have to talk about that because many of these patients are not a candidate. So here you have, again, this is a proposed algorithm for FLT3 mutated patients, having a look at least at HMA venetoclax, but HMA maybe plus gilteritinib. So can you add a FLT3 inhibitor to a non-intensive backbone? HMA ven changed the world, so it got older patients into remission and living longer. And you can use HMA ven in FLT3 mutated AML, but the success, if you will, of that was primarily driven by the TKD. The ITD patients you can get into remission, but the overall survival is driven primarily by the TKDs, showing that patients with an ITD who are older, who are getting an HMA ven backbone, weren't doing well enough just with the doublet. So what else can we do? So again, these are long-term outcomes looking at HMA venetoclax, but here with the addition of a FLT3 inhibitor. So these are retrospective data. MD Anderson has been driving the so-called triplet regimens, in this case, looking at quizartinib or gilteritinib. And the idea was, okay, HMA ven alone, again, changed the world, but the primary benefit is in the TKD patients. What about the ITD? Well, it was starting to look like a triplet regimen with the addition of a FLT3 FLT3 inhibitor was improving RFS and OS. These are, again, not randomized data, but showing that, first of all, they are combinable. These drugs are well tolerated enough that they can be combined, and maybe we can help some of these older patients who will not do well with an ITD and then HMA alone. So here you can see that this is an ongoing, again, arms race. We have lots and lots of trials, but what we are trying to do, we know already we have standard of care for relapse disease, but nobody wants to relapse. We want to have combinations with standard chemotherapy, but what we would love even more is to build out less intensive regimens to drive MRD negativity, to avoid standard chemotherapy for some of the patients who can't tolerate it, and then to ask the all-important question of, is it possible that we don't need to transplant everyone if they are actually completely negative by high sensitivity MRD assays, and in co-mutated patients with NPM1 using completely negative both for NPM1 and for FLT3. And I call your attention to some abstracts that are going to be specifically addressing this topic at ASH. So here you can see some of the national guidelines. Access is different everywhere. Not every place is exactly the same in terms of the approval, but you can see that a FLT3 inhibitor with chemotherapy is what you want to be doing. What you can see at the bottom is a little bit of differences in terms of both availability and what is recommended in the post-allo setting, with the approvals not the same in the EU and in the US. I encourage everybody in your area to look specifically as what is actually approved, and then also what is the access in your part of the world. This is, again, an international audience here, I know. But the concept here, and the concept of looking at the approvals and what is available, is this idea of maintenance therapy. And you can see this is from an article that we put out actually in Blood in the How I Treat section. I call your attention to the article for not only for FLT3, but here, if you look at what the plans are for a FLT3 patient, you've got to think about, am I going into a transplant or am I not going into a transplant? Where do we have data? If we have peri-transplant MRD positivity, we have data from Morpho that a FLT3 inhibitor would be a benefit. If you are not going into an allo transplant, are you MRD negative? Do you have an MRD assay? And then being careful where you are and what the access is to the different agents. Do you have an ITD? Do you have a TKD? What do you have access to? But maintenance regimens being strongly, strongly considered, especially if you don't have access to an MRD assay that you can rely on. In conclusion, we know that midostaurin and quizartinib improved survival when they added to intensive induction. Allo in remission is a significant predictor of overall survival. That's how we started curing people with FLT3. But maybe some of these patients can do okay if they are absolutely negative by high sensitivity assays. This is the PCR NGS assay. See if you have access to it. We know that gilteritinib is improving relapse risk if you have MRD positivity. We also know that any level of MRD positivity is dangerous. And we know that if you don't have access to this assay, you want to be particularly cautious about withdrawing a FLT3 inhibitor if you're not sure that you're negative. Early data from the triplets are incredibly encouraging, and we hope that they are going to change everything for the low-intensity backbone patients.